Hello friends, welcome back to Endo Tales from Life. This is a kind of surprise and an unexpected video for both you guys and myself. Yes, we had actually planned our next tale on the bioceramic obturation technique, but coincidentally today I had two interesting cases of mandibular second molars in my practice which I treated. So when I was doing this case and documenting, I thought why not make a video on this, because both had two different and interesting anatomies and something that is very clinically useful for practitioners who treat these mandibular second molars, which are slightly tricky compared to the mandibular first molars. We'll see why in this video. Thank you for watching.
Mandibular second molars have both similarities and differences when compared to that of a mandibular first molar. They are similar in morphology to that of a mandibular first molar, but these teeth are relatively smaller in size and the roots of these mandibular second molars are in closer proximity to each other, and these differences cause some different representations of the anatomy and canal location in the clinical scenario, which makes these teeth challenging to treat. So in today's video, we are going to discuss about two cases that I happened to treat on the same day, and both cases were referred cases for endo, and I was lucky to have two different anatomies, different representations on the same day. And when I was doing this case, I had this idea of making this video which might be useful for my viewers. So in general, when mandibular teeth, mandibular molars especially, when they have three canals, we all know that they follow some laws of symmetry. When there are just three canals, the distal canal is generally larger in size compared to the mesial canals, and also it is present exactly in the center between the two mesial canals. And when there are four canals, you will see that the distal canals are not in the center, whereas they are slightly off-centered, and also the size of the distal canals varies. When there is a single distal canal, you will have a large distal canal that is exactly in center between the two mesial canals, whereas you can see in this scenario when there are two distal canals, they are smaller in size and they are not present in the center. So this is a simple clinical tip when you treat mandibular molars for you to know whether there are three or four canals. When it comes to the mandibular second molars, this is the difference. The one on the left is a mandibular second molar and the one on the right is a mandibular first molar. So you can see that the teeth are relatively smaller in size, and also one of the biggest differences that we need to be aware of is the distance between the two mesial canals may not be as far as you see in the mandibular first molar. So let us take this clinical example. In this case, this is also a mandibular second molar. You can notice the distance between the two mesial canals. So when you treat mandibular first molar, we are used to search the mesial canals little far away from each other. For example, if this is my mesiolingual, we search for a mesiobuccal a little far away from the mesiolingual. But when you treat mandibular second molars, you need to be prepared for locating these two mesial canals extremely close to each other. So here we go. As I mentioned earlier, we have two cases with two different representations. The case number one is the mandibular right second molar, tooth number 47 with distoproximal caries, and this is the preoperative radiograph. So apart from showing you the anatomical representation, let us also discuss about how we went about this case clinically. I will also show you the workflow of these cases. So the most important aspect is rubber dam isolation. So with rubber dam, the one tip that I can give you guys is to do the occlusal reduction rather than using any of the straight fissures or tapering fissure burrs. It's very easy to use these wheel burrs as the axis and orientation is much simpler with the help of these wheel burrs. And since we are anyway planning to give a full coverage restoration, be it an onlay or a crown later, a little bit of occlusal reduction will be of help to give me a good occlusal table and also stable reference point. And then we start approaching the axis from the defect. So this is called the caries centered axis concept or the defect centered axis concept. We initiate the axis from where the tooth has been affected. So we start with removal of the distal-proximal caries, and this will help us reach the pulp chamber in an easy way. And after that we start with the deroofing procedure. So I only do a tentative access with burrs and air rotor handpiece, high speed air rotor handpiece. And once we achieve a preliminary shape of my axis cavity, then we do the final refinement with ultrasonics. So at this stage, we stop using air rotors. We use ultrasonics, which will help me work with vision, and it's very slow and precise so that we don't unnecessarily remove excess of healthy dentin. I'm able to remove exactly where I want to remove. Even caries removal is possible. And at this stage, we stop here. And as you can see here, this is my axis, and this much of axis is good enough for me to complete this case. And you can see that there is a moment of caries that is left behind in the gingival seat. This is intentional because trying to remove the caries in the proximal box, almost near the gingival seat, can tear the rubber dam sheet and cause some problems during the workflow. So that is why we've intentionally left behind some caries over there. And during the axis, after the axis is completed, I start locating the canals, and I'm able to see only two canals now. So whatever canals that we locate, I prefer them to be located, scouted, and also determine working length radiographs. So even though we use apex locators, I still prefer to see the files at the working length. So this also gives me a clue about the anatomy and the difficulty of the case. And you can see here there are two canals that I can see with two separate exits. Then we start with the rotary instrumentation, followed by cleaning and irrigation. And this case, after completion of the cleaning and shaping, I can confirm that there are just two canals, because there are just all I can see is the mesial and distal in a straight line, and also the size of the two canals are the same. So this is how I need to make sure I'm not missing on the third canal, which we also confirm with radiographs. And this is the master cone radiograph. Then we go about with obturation using the bioceramic technique, and this is the post-op radio result. So after I finish my endo, I do the orifice sealing immediately. So in this case, since it's a referred case, I'm not going to do the final restoration. So even if I'm going to do a restoration finally or not, that doesn't matter. I do the orifice sealing immediately on the same visit. So this is the protocol. So this we work with microscope. We have the orange filters on. I apply the universal bond. Since it's only bonding to dentin, I don't have to etch. So I apply the universal bond over the floor of the pulp chamber that has been cleaned well, and light cure it. And followed by that, we inject some flowable composite onto the floor and cure this as well. So now I have a complete coronal seal. So at this point of time, I can remove the rubber dam now and address the caries that is present in the gingival seat, which we had intentionally left behind at an earlier point of time. So you can see here, now we remove the rubber dam, and now I can use my long neck burrs or my conventional burrs and remove the caries that was left behind and also do any gingivectomy if needed, so that in the next visit it's going to be much easier for us to design our final restoration. So here we have given a provisional restoration and referred the patient to the referring doctor. If I'm going to do the onlay in the next visit, I can just remove the temporaries, and my gingival seat is also elevated. It's very easier for me to make my final preparation and impression. So now let's discuss the case number 2. This was mandibular left second molar 3-7, and after access this case was a little tricky. Here you can see that I am not able to see two separate orifices that are wide apart from each other, but we know that mandibular second molars are always tricky, so I will use some additional magnification, and you can see that when I zoom deeper there is two separate canals. The only thing is they are little deeper from the 2 millimeters down the pulp chamber floor, making it a little difficult without magnification. So when I was taking my master cone radiograph, you can see that almost 1 to 2 millimeter short of the apex, they are two separate canals. So we again finish the case with bioceramic obturation. You can also see that in this case also in the disto proximal gingival seat we are left behind some caries intentionally during the initial part of my treatment, so that my rubber dam sheet is not torn or my isolation is not affected during my endodontic treatment. And after I had given my coronal seal with the flowable composite, now I can remove the rubber dam and remove the left behind caries and any gingivectomy or deep margin elevation if needed, give the temporary and send the patient off. So this case has three canals which could have been easily missed if not for the logical understanding of the anatomy and magnification in the clinical scenario. So the same workflow, we temporized at this visit, but we still provided a good orifice seal. So the take home message of today's video is this: whenever you treat mandibular second molars, beware. Sometimes there are three canals and the two mesials can be extremely close to each other, but also in few cases there are just two canals, and with magnification or an intraoral camera picture you can also confirm this by the simple clue that they are both in a straight line, and most importantly both the mesial and distal are of the same size. Thank you for watching this video, and for more such videos and more such educational content you can follow me on different social media platforms. Thank you. We are coming up with the next video very shortly.